This is a follow-up video going on. This is supposed to go over all the medication management for migraines from a neurologist type perspective, and I'm leaving so much out, but there's just so much, so I'm going to try to condense this as much as I can. And I somewhat nonchalantly glossed over the types of migraines, and we're still not going to go over that in this video either. But these types of migraines are helpful in an emergency room setting, and also even from a neurology perspective, you still want to be on alert for those red flags. Snoop is the common red flag. S is for symptomatic or systemic. So if they have things outside of their head, obviously that's going to be concerning, right? Maybe it's not just a headache or a migraine. N is for neurologic signs. That kind of goes along with systemic, like if they've got like a droopy eye or something like that, which can happen in cluster headaches, but it can be a sign that maybe this is a stroke. And then there's onset. You've heard of thunderclap headaches. That could be a concern for a brain bleed, a subdural hemorrhage. And older age, people don't get migraines suddenly when they're older. It just doesn't happen, and typically that is going to be a concern for a brain bleed or a tumor, because migraines are typical in younger patients. Again, women in their childbearing years. People tend to age out of migraines. And then P is a pattern change, like their migraines used to be like this and now they feel totally differently, or positional. So in pain management, if they have a migraine within 48 hours of an epidural steroid, that could indicate a spinal leak, which can repair itself but may require a blood patch. These migraines get worse when you stand up and better when you lay down, because of that intracranial pressure. Going back to the treatment algorithm, we're going to start adding in some details, because in neurology you should know all of this in pretty good detail because you are a specialist, right? So as I said, we're going to start with ibuprofen, tylenol, Excedrin is over the counter, and then the one prescription NSAID that I'm aware of that's available for migraines is Elixib, and that is the name brand Elixib, and it is basically liquid Celebrex, and it is the fastest acting treatment for migraines, or at least was until very recently. And part of that is because it's liquid and it's a selective COX-2, which is what Celebrex is, so it doesn't cause that GI upset either, which can be difficult for people with migraines because they have that nausea already typically. And then you've got your Triptans, which work by vasoconstricting through 5-HT receptors, which are related to serotonin. Ergots also have vasoconstrictive activity, so all of these have vascular effects. And the Triptans, there's 6 of them, and since you're in neurology, you know all of them. Sumatriptan was the first one, Imitrex, and that one comes in the most options. It comes in tablets, nasal sprays, and injectables, and it comes in a 25 milligram dose, 50 milligram dose, and 100s, with the higher dose being more effective. And you can take one dose, and then after 2 hours, if you still have a migraine, you can take a second dose. And you do, with any abortive treatment, want to try and get that first treatment in within the first 2 hours to be the most effective. Then you've got rizatriptan, with the benefit of this one being that you can use it in as young as 6, which I think the first word rise is contradictory, because rise you think older, but actually it's the younger people that you can use rizatriptan in. There's elatriptan, which there's some evidence that this would be the most beneficial for most people. And then there's naratriptan, which insurance tends to like for whatever reason, I'm not sure. Then there's olmatriptan, and I think one other one that we won't go into right now. Then there's ergots. There's tablets available. The one that I'm most familiar with is Trudeza. That comes in a nasal spray, and we have samples of those, which is why I know that one. And then there's CGRP inhibitors or antagonists, known as Nurtec and Ubrelvy. Nurtec comes in a single dose, and it's the only migraine medicine that is approved for both prevention and abortion, because what they found was people that would take Nurtec wouldn't even have a migraine the next day. So it seemed to not only prevent a migraine in that day, but even would carry over into the next day. And it was only made in that singular dose because it seemed to kind of last for like 24 hours or so. So in a preventative way, you prescribe it every other day. And then if you have a breakthrough migraine on that off day, you can take one on the off day, but no more than every 24 hours. Not because it's going to hurt you, because it's unlikely to help you, because it should last for at least 24 hours. I can't overemphasize the safety of CGRPi inhibitors, even though they haven't been studied in pregnant or breastfeeding women or children. They are very safe in the way that they act. They're just targeting that protein. And again, Nurtec, one dose every other day. And Ubrelvy comes in 50s and 100s. However, there's no evidence that 100 is any better than 50. So I'm pretty sure it just comes in 2 to confuse you. And the benefit of Ubrelvy is patients feel like they have more flexibility because they can take one dose, and then if they still have a migraine 2 hours later, they can take that second dose, which recalls back to how they used to take their Triptans. So some people like that ability to get something more if they need it. So you can take Ubrelvy in that pattern. And then finally, we get to our oh crap patients that have done all of these and they're blowing up the phone line or they're messaging you through the portal. We've got Reyvow. Reyvow is a controlled substance. Now, it also works on 5-HT receptors in a similar way that Triptans do. However, it doesn't cause vasoconstriction. If you recall, Zofran helps with nausea. That also affects 5-HT receptors. So it's not quite like Zofran. It doesn't help with nausea, but it does cause sedation. We're not really sure how it helps migraines, but we do know it is the only migraine medicine that works even 6 to 8 hours after the onset of a migraine. So how I tell patients to take this is to keep it at home. And if you've tried everything else, then you can try Reyvow before you go to bed, because it's going to make you sleepy and you're not supposed to drive after 8 hours. And what I was trying to tell you is a drug rep told me Reyvow was studied more recently. It came out more recently, and the conditions it had to pass were more strict than like Triptans or ergots. So they said, oh, if these came out now, you also couldn't drive. Or like there would also be that warning that you shouldn't drive. But they don't come with that warning because these have been around for a while, whereas Reyvow just came out. So it's only name brand and comes in a tablet, and there's a warning on there, you should not drive for 8 hours after taking. But at least it's kind of that backup thing. And it is a controlled 5 substance. Controlled 5 is like the least controlled of any of them. And there's like some sleep aids and things that are controlled 5, but like Lyrica's controlled 4. Like even Lyrica's more controlled than Reyvow is. Other things that you can do for that patient that's like, oh my gosh, I'm dying, is steroids. You could do a Medrol dose pack, or you could do prednisone, because at the end of the day, a really bad migraine is a type of inflammation, so steroids can help with that. And ketorolac, which you can prescribe as the 20, or I think it comes in 10 milligrams every 6 hours for 5 days, or 20 tablets, which they don't have to take all of that, but this is similar, like steroids and ketorolac is similar to what a migraine cocktail would look like in an ER. You can also order some infusions at infusion centers for people whose migraines just aren't going away. Even from an outpatient setting, you can order, if you're a neurologist, you can order infusions for those people. The other new medicine that came out is Zavspret, which is basically a nasal spray. Zavspret is basically a nasal spray Nurtec. It came from the same people, and the nasal spray activity is supposed to be faster acting than Nurtec, which is dissolvable. Ubrelvy is a swallowing pill. And the Zavspret, name brand only, it just came out. Insurance is difficult, insurance coverage, but it might have very similar onset, less than 10 minutes, as Elixib, which Elixib was supposedly the fastest, but now Zavspret's also fast. And I forget which Triptan has the fastest acting, but that's a pretty detailed list of the abortives that you can try.